extra, and Dr. Shail Vasada is introducing us what is coming up and what is happening in the pediatric cataract surgery IOL power calculation.
So I think after these wonderful talks on IOL power calculation and the newer biometers, I think before we move on to pediatric, I think there are two main take-home messages that I learned from this course so far is that the best part about now the newer generation formulas is that we don't need to remember those tables that if the axial length is smaller than this, then these two formulas longer, these two formulas for normal axial length, this formula. Most of the newer generation formulas like the Barrett's Universal 2, the Olsen, the Hill RBF work well or as well across all the axial lengths. So if you are familiar or if you are used to one formula, you don't need to keep shifting from one patient to the other, from one formula to the other. And even better, icing on the cake, all of them are available free online for everyone to use. So we'll now move on to pediatric IL power calculation, and I think pediatric population is very different from adults for the simple reason that they are not going to cooperate very well to give us those wonderful accurate readings with the latest and the most expensive machines that we have. We do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. Accurately determining IOL power is a challenge in pediatrics for multiple reasons. One, like I already mentioned, the difficulty in getting good readings, and also because this is a growing eye and not a fully matured eye which is not going to change post-operatively. So there are three major concerns: the measurements, the formula, and how much you undercorrect or you overcorrect depending on the age and the laterality of the cataract. We do require biometric measurements, and getting them is often very difficult, and for most of these children you would require examination under anesthesia because they are not going to cooperate to sit on an optical biometer. So generally it is best done by handheld keratometers which can be done very nicely across axial lens without actually having to use speculum in most cases. But in certain very small children, 3 months, 2 months, 4 months, you may even have to put a pediatric eye speculum to get good keratometry readings. As has been highlighted very wonderfully in this course, the same goes through even for pediatric eyes. Try and achieve an immersion biometry as far as possible in all possible pediatric eyes under anesthesia. There will be certain exceptionally small eyes, micro-ophthalmic eyes, where putting even a pediatric Prager shell may be impossible to do, and for those eyes maybe a contact biometry may be considered an alternative, but as far as possible immersion biometry under anesthesia. There is very little data available on the normative database of the axial length of growing children or keratometry of children with cataract, because an eye with a disease behaves very differently from a normal, so-called normal eye. So this was the normative database published by Dr. Rupal Trivedi, Dr. Ed Wilson and their group, where they found that in a very young child the corneas tend to be significantly steeper, and beyond 6 months is the time when the keratometry tends to stabilize to become the sort of average adult keratometry. Regarding the techniques of axial length measurements, again there have been several articles even in pediatric eyes to show that when you use contact as a routine, you end up with an average one diopter shorter IOL power calculation. Optical biometry remains theoretical for most pediatric population. It's only children beyond 7, 8 or 9 who are able to sit comfortably that will do that. Now the second is we have reasonable amount of data that we have captured now with immersion biometry and keratometry. Now how do we use that data and which formula do we use? Do we fall back upon the newer Barrett's Universal, Olsen, etc., so on and so forth? So pediatric eyes, because they are growing eyes, the effective lens position and the anterior chamber and the posterior segment diameters are constantly going to keep changing. So honestly, in today's time, there is no consensus as to which is the best formula as far as pediatric eyes goes. and that goes by the several number of publications by all the stalwarts in pediatric cataract, and each of them finding in their own study some or the other formula which works better in their hands. Across all of the major publications, the SRK2 and the SRKT and the Holiday 1, these three have been consistently found to be reasonably accurate across all pediatric population. We did our own comparative from our own pediatric data sampling, and we found in our hands the SRK2 and the Holiday 2 to give us the most accurate results in these eyes. So for us, the choice of IL formula in pediatric eyes is the SRK2, SRKT or the Holiday T, and this is our data which we published well, where we found both of them to be most accurate amongst others. The third is, which is even more important, is how are you going to target these patients? And we heard about perfect target emetropia, no spectacles, no glasses in adults. However, that changes significantly in pediatric eyes, because these eyes are going to grow longer as they grow older, which means the eyes are going to become more and more myopic as the children are going to grow. So the criteria to determine how much you want to target the patient depends on the age of the surgery and the axial length at that current point of time. So not all eyes of 6 months would have the similar axial length. Some eyes are inherently myopic even at 6 months, so you may want to change your target refraction accordingly. There is this debate that, you know, if you emetropize these eyes at a very young age, you are going to have significant high myopic shifts post-operatively, which in our own series we have several patients with more than -8, 9, 10 diopters myopia, where we did not undercorrect very significantly in the early on period. And the rate of axial growth following congenital cataract surgery is still not very well understood, or is still not very well studied. So the newborn axial length, on an average, the normative database has been shown to be about 16.6 millimeters. There is an extremely fast growth in the first 6 months, a slower infantile 6 to 18 months, and 18 months to about 5, 6, 7 years is even slower than what is there in the first year and a half. And this is the sort of gold standard normative database published way back in 1985. Not much of normative database in pediatric eyes after this has been come up. So the rate of axial length is higher in children less than 1 year of age, so that's the most important criteria. It is higher in pseudophakic group than in aphakic group. So if you're planning to leave a child aphakic, you may want to undercorrect a little less. They tend to grow a little lesser compared to pseudophakia, and higher unilateral pseudophakia, because that is likely to be the amblyopic eye. If there is a unilateral cataract, there is a very high chance that that is likely to be the amblyopic eye, and therefore it's likely to grow much faster than the other normal eye. So the debate always rages is whether you do an emetropia correction. The advantage is that the child would be able to see well immediately, therefore lesser chances of developing deep amblyopia. However, there is an extremely high chance of extremely high myopia occurring in the future. Whereas the other debate is to undercorrect these children, that is, leave them hypermetropic at the time of surgery. Then there is the higher chance of amblyopia in the early post-operative period, because you need to make sure they are strict in wearing their glasses or contact lenses, but lesser chances of extreme refractive error in the future. So the key in most of these pediatric eyes is to undercorrect, and the undercorrection once again depends on the age of the child. Younger the child, more you undercorrect; shorter the eye, more you undercorrect; and unilateral eyes you undercorrect more. The existing strategy, there have been several guidelines. The Dehan guideline gives guideline based just on the axial length. You pick up an axial length and pick up an IOL power. The most commonly used plaguers is based on the age. Once again, you choose the undercorrection based on the post-operative refraction based on the age, and similar other nomograms have been published by Dr. Ed Wilson and their group. At our center, what we like to prefer is the younger the child, more the undercorrection. That is, children less than 3 to 6 months, we try and undercorrect by 30 to 35%. And as they keep growing older, we undercorrect lesser and lesser. And more than 6 years, up to 15, 16 years of age, we hardly undercorrect. So we just choose one power on the positive side. So if, for example, if it's a 9-month-old child with a cataract and an metropic power of 32 diopters, following our strategy, we would reduce that by about 25%, which is about reducing 8 diopters from that power, and we would end up with about a 24 diopter power. So I think to conclude, pediatric eyes behave very, very differently compared to adult eyes. There is difficulty in achieving accurate measurements. The IOL formula is still a debate which is unanswered. And target refraction, I think there is an overall consensus to undercorrect significantly. Younger the child, more the undercorrection. The percentage varies from the practice to practice. So I would like to end my talk at this point of time. Thank you so much.
So I think now we'll cover one more topic, and that is all power calculation in toric IOLs. And Dr. Shail will be speaking about it. While Dr. Twinkle sets up the laptop, any questions so far? We are talking about the formula, not the machine here.
I think that's a very valid question, because now most of us are in the phase of practice where we are going to move on to upgrading our biometers. So I think now time has come that if you are buying a new biometer, swept source OCT based biometry is likely to be the one you want to step ahead to, particularly if you are buying a new one, for two reasons. I think you have lesser and lesser use of immersion with the use of swept source. For example, in our study where we compared the TOMI versus the LensStar, we could achieve axial length measurements in 98% of cases with the swept source compared to 84 with the LensStar. And they are likely to give now more accurate keratometry, supposedly with incorporating posterior cornea in some of the cases. But I think as far as keratometry goes, LensStar holds as good as any other optical biometer. But I think swept source OCT is probably the one which we would want to upgrade to.
So technology-wise, it's of course the swept source, and now there are 2-3 companies now in the fray. In fact, somebody was talking in one other hall that now there is all-in-one coming in. So that's how it's going to happen. A swept source with the tomography and all that stuff.
So typically, yeah, the question is that in children, if we have operated and the child ends up having +8 diopters, what do you do with that child? So what we typically do is that we typically tend to give the glasses to these children immediately post-operatively in the first week after the surgery. And if we are planning to operate the second eye, then immediately 2 weeks after the second eye surgery, we give binocular glasses. We typically don't tend to give them bifocals or progressive glasses in children less than 2 years of age, because their world is limited to quite close by. So we give them single vision high hypermetropic glasses, and children, they accept almost anything that you give them. That's the beauty, because they see better with them. So glasses is something which we feel they won't tolerate well, the high number glasses, but surprisingly they tolerate them quite well. Absolutely. So the debate for many years was to have the debate was at what age should you consider putting an IOL in a child's eye. And the debate was mainly in children less than 2 years of age. Beyond 2 to 3 years of age, the eye is usually well grown and safe enough to consider an in the bag IOL implantation. We did a randomized control trial comparing bilateral aphakia versus bilateral pseudophakia in children less than 2 years of age. What we found was that the end of 5 years of the follow-up, both gained the same amount of vision. The difference that we found was that the pseudophakic group achieved it at a much faster pace compared to the aphakic group. And the practical difficulty in leaving aphakia in children, contact lenses and all those things sound good on theory and in paper, but most of these children tend to come from lower socioeconomic classes. So all those, keeping those practical difficulties in mind, we find that if the eye on table, if you find is suitable enough to consider IOL implantation, you should consider. However, anatomically, but however, bilateral aphakia is still an excellent option. Yeah, of course. The pseudophakic group required lesser.
5 years.
Yes. The pseudophakic group required significantly lesser power of spectacles, and none of them required contact lenses.